It should start on time.
Buat sikit ni.
Lagi.
Okay.
Yes.
Okay. All right.
Maybe not.
Uh-huh.
Okay.
Yeah.
Okay. I will.
All right.
Good morning, afternoon, and evening, everyone. I'm Goff, Chair of ISN OSEA and ISPD APC, and it's a real pleasure to kick off today ISPD and ISN PD case discussion. Thank you for logging in from right across the APEX region. Even if you have to put off lunch or dinner or both,
All right.
this discussion and just box ticking exercise, they a chance to ask for us to brush up on our diagnostic reasoning, swap regional perspective, and learn from real world challenges. Today, case teaser that we circulate through the email and WhatsApp set the state of cloudy PDF friends diagnostic dilemma. We follow the journey of 57 years with the diabetes hypertension. And let's see how the story unfolds. The case will be presented hosted by Dr. Tengku Ampuan Lahiman, Klang, Malaysia. We are in for a fascinating discussion. Please feel free to jump right in, drop your questions in the chat or raise your hand. If you speak, just unmute yourself and let us know your name and where you're joining from. It's always nice to put a voice to a country. So let's get started. Over to you, Dr. Suguna and Dr. Eileen. Are you ready, Suguna?
Yes, Suguna. Yeah. Okay.
Not yet.
Can see my
so you
slide.
have
Not.
to share the slide. So anyone, if you don't get for the teaser, you can see the chat on the chat.
Dr. Irene can see my
Yeah.
slide?
Yes. Yes,
Okay.
Suguna, we can see your slides. Yeah.
Okay.
All right.
Okay, I
Thanks.
proceed. I'm Suguna from nephro trainee from Hospital Tengku Ampuan Rahimah, Klang, Malaysia. So today I'm going to present about the cloudy PD effluent diagnosis dilemma. So this is a 57 years old Malay lady, para 5, widow. She is housewife, non-smoker and non-alcoholic, and no family history of kidney disease or malignancy. She was underlying with the diabetes mellitus, hypertension, dyslipidemia, bronchial asthma, epilepsy, and also diagnosis as hepatitis B. And she have no past surgical history. She was established end-stage kidney disease in February 2025, is secondary to diabetes mellitus, when she presented to us with a fluid overload symptom. So that admission, when we proceed with the ultrasound KB, kidney showed is a bilateral shrunken echogenic kidney. The right kidney is 9.1 cm, the left kidney was 9. And we counsel her for renal replacement therapy and hemodialysis versus CAPD, and she opted for continuous ambulatory peritoneal dialysis with the assistance of doctor, and financial was under SOXO. So we inserted catheter, Tenkov catheter was inserted on the 4th of March via peritoneal and procedure was uneventful. She subsequently was discharged well. Our plan was to wound inspection on the 10th of March and also flashing on the 12th of March. We discharged with the felodipine 5 mg OD, atorvastatin was 20 mg one night, Lasix is 80 mg OD, tabzincopro 11 OD, and also steroid lactulose 50 ml TDS, epilim is 200 mg BD, pantoprazole was 40 in our CAPD unit on the day 9 post Tenkov insertion. Noted the PD fluid was turbid, and she further history she complained, but noted it is more episode of the loose stool for past 9 days. Otherwise, she denied fever and vomiting. She got history of taking syrup lactulose, denied history of eating outside. So on examination, she was alert, not tachypneic, and not septic leaking. BP was 145/80. Pulse rate was not tachycardic 74. No documented fever, and she was stable under room air. On auscultation, lungs, there's a bilateral crepitation. Cardiovascular system is unremarkable, and abdomen on examination was soft tenderness on palpation, and they noted there's a pediatric edema until level. So we took the baseline investigation. So initial FBC was denoted, total white was elevated with 19.08 with a normochromic, normal cystic anemia. And renal profile noted urea was 27.7 with the potassium was 5.4 and creatinine was 679. And CRP was not elevated as 2.3. Albumin was 16. Otherwise, ALT and bilirubin was normal. So we send the PD fluid for gram stem. That there's a past cell was few there's no organisms seen, and cell count was 250 with polymorph was 0 and lymphocyte was 25. So that time our working diagnosis was a pre-initiation PD peritonitis. So we started her with the IV ceftazidime, 2 gram stat and also 1 gram OD, and cephazoline is 2 gram stat and 1 gram OD. Subsequently, she was started with the intermediate peritoneal dialysis via cycler, and she completed 72 hours intermediate peritoneal dialysis with the total UAP extraction was 1,132. The PD fluid after started antibiotic was subsequently was clear. So the investigation trend, the PD fluid trend sent in the ward noted the cell count was become a 0 and also polymorph was subsequently 0, lymphocyte also 0, and patient was on IV ceftazidime and cephazoline while we start back the CAPD training. So retrospectively, when we trace back the PD fluid culture, all came back as a PD culture came back as no growth. AFB and fungal CNS was so negative, and blood CNS send was no growth. The stool culture and CNS was sent was negative. And patient was inpatient, started CAPD training, and we noted there's a slow inflow and tight outflow with a minimal leaking at the catheter site. So the day 2 of the CAPD training noted slow inflow and poor outflow, and we try to manual flush, but the outflow was still poor. So proceed with the abdomen X-ray. We noted the Tenko was migrated. So our impression that time was a migrated Tenko catheter, and we are thinking of possible augmental wrap. So we decided, since she completed antibiotic 2 weeks, and she decided to remove the PD catheter and reinsert the PD catheter. So while optimized for the reinsertion of the PD catheter, we temporarily inserted femoral catheter, and we started hemodialysis her. So subsequently, patient proceed with the Tenkov removal and reinsertion on 3rd of April. And patient also post Tenkov insertion, removal and reinsertion. She was discharged on the 7th of April and planned to wound inspection on the day 7 and flushing on the day 10 post-operation. But and for on the flushing of day 10, we noted PD fluid was clear and patient was well. So on the second time when we start CAPD training, the 14th of April, the first exchange noted PD fluid is turbid, but when further exchange, patient has no fever, no abdomen pain, no vomiting, no UTI symptom. So when the patient was doing the CAPD training, the exchange in the CAPD unit, noted there's a patient have the loose stool, watery stool in the pampers. So when further examine history, patient claimed there's a passing of fecal material from vagina, and she noticed when wearing a pampers. So the watery stool was increasing in the frequency each time CAPD exchange. There's no blood in the stool, claim no pain when the application, and no issue of perineal tear or perineal abscess previously. So on the examination of that time, patient was alert, not septic looking, not tachypneic. BP was 159 over 72, pulse rate is 82, patient is afebrile and saturated well under room air, and DST was 8.2. Lungs was clear, cardiovascular is unremarkable. Abdomen examination, abdomen was soft, non-tanker, tank side was clean and no erythema noted. Pediatric edema notice anti-mission. I need a pre-rectal examination. There's no external hemorrhoid or no mass noted. Proctoscope, there's no obvious fistula was seen. But vaginal examination, we noted feces is coming out from the vagina. So our diagnosis that time was a PD peritonitis and through rectal vaginal fistula based on the history and also clinical examination. So we sent the baseline investigation also this time. The total white was elevated 12.49, hemoglobin was 10.1 with the platelet was normal 398. And the urea that time was 16.7, potassium was 3.9, and creatinine was 626. CRP was not raised, it's 1.2. Otherwise, there's a hypoalbuminemia, albumin is 14. And we send the PD fluid. Pus cell was few, fast cell was noted, and no organism noted, but cell count was 90, and polymorph was 30, and lymphocyte was 0. So we admitted her and we started with IV cefazolin and also ceftazidime, and we covered with the syrup nystatin also for fungal prophylaxis, and we refer immediately to surgical team. At the same time, we arranged for CT abdomen pelvis and cystogram, and also refer surgical for colonoscopy. So meanwhile, we the CAPD, we inserted IJC and also started hemodialysis temporarily. So seen by surgical, they proceed with the colonoscopy. So colonoscopy noted there's a 5 cm from the anal verge, there's abnormal mucosa raised, and they also noted there's irregular circumference at the rectal wall, likely fistula. The arrow show as a fistula site in the picture, colonoscopy picture. So we proceed with the CT abdomen and pelvis. So this is a CT scan, abdomen and pelvic. So basically, this is the vagina. So they put the tampon. This is the rectum. So when they give the contrast, we can see there is a contrast in the vagina. So this is suggestive for there is a fistula tract, rectal vagina. So we also can see there is there's a small air linear tract communicating with the lower rectum and also posterior wall of the vagina, which suggestive for the rectal vagina fistula tract. So we send this time also we send for the PD fluid for AFB, fungal, and also CNS. All came back is negative, and the blood CNS also no growth, and PD fluid which we sent from the OT also it was no growth. So this patient surgical going in operation, they did a laparoscopy assisted supine colostomy and also evacuation. So intra-op, they noted upon entering the peritoneal cavity, noted there's a multi-color collection around like 800 cc, but there's no slough or addition seen. There is a liver bed is no slough, and small bowel and large bowel is normal actually. Noted Tenkov over the left peritoneal region was a normal. That's the ileocecal junction brought out from the loop of ileostomy. So intra-op, they send for the HPE from the rectal vagina fistula tract and also from the rectal tissue, all not suggestive for malignancy. So pap smear also was sent, which is also negative for intraepithelial lesion or malignancy. So this patient is subsequently in the ward completed total 3 weeks of cefazolin and 3 weeks of ceftazidime, and she was subsequently converted to hemodialysis 3 times per week. And then day 6 of post-operation, she was well. She was discharged to continue the dialysis at the private center, and we give the ABF date for creation. So So today, I would like to
Maybe Suguna, you would want to hold on for a while. Is there any question from the floor with regards to this case?
There will probably be somebody maybe join us late. So maybe you
Okay.
wrap up our list of problem a little bit.
Okay.
Maybe
Well,
someone cannot follow us.
yeah. I mean, basically, this is like a new ESKD patients who actually decided for a CAPD. So a PD catheter was inserted. However, post insertion at day 10 of a flushing of a catheter, we noted that there was actually a turbid PD fluids. So at one point, actually, we were thinking whether it's the chemical peritonitis, in which in our lab, we can sound for some differential counts. The eosinophils was a bit high, which was a bit perplexed that she does not really have obvious symptoms. Well, she does have a bit of a diarrhea, but no fever, doesn't look septic. So subsequently, while waiting for the cultures to come back, so she was empirically treated with IV antibiotics, which eventually the PD fluid cultures came back as negative. Unfortunately, she also has another episodes of catheter malfunctions. The catheter was migrated, it was removed. So in our setting, it would be easier for us to remove the catheter and reinsert C, rather than referred to our surgical colleague for a laparoscopic reinsertions. So this is what we did. And again, I think it's about 3 weeks post catheter insertion. Again, when we wanted to retrain the patients, we noted that the patients has another episodes of cloudy PD effluence. So this was some of the workup. Of course, our workup along the way will be culture negative peritonitis lah. Yeah.
Anyone want to raise any comments or any questions or want to discuss?
Hello, I have a question. Can you all hear me?
Hi.
Yeah.
Yes, we can.
course.
Yeah.
So my name is Upshat. I'm attending from Ethiopia now. So do we know any her previous history of her gynecologic previous history? I think if it was something which was there before the initiation of peritoneal dialysis, you might have some kind of like abnormal discharge or bleeding or any previous gynecologic history. Do we know that I had missed, or do we know that history? Thank you.
Yeah. She does not have any significant gynae history previously.
Let Suguna answer.
Oh, yeah. Right.
Can I ask one question?
Yes.
Or just a comment? So look, a very, very fascinating case. And I admire the persistence of the team as well as the patient to continue on PD despite all that was happening. The pre-PD peritonitis time, I was, the things that were coming to my mind were something like a eosinophilic peritonitis or even, because something like Kyle, there was a milky collection in the on laparotomy, and I was wondering whether there was some consideration for that. I mean, the diagnosis of PD peritonitis is a bit difficult, and it's something new that we're now trying to focus on. And especially when, in terms of when we are putting enough fluid and draining it, the ISPD recommendations are to keep the fluid for 2 hours and then send the cell count. And for pre-PD peritonitis, that often does not occur. So usually the nurses will just put in the fluid and remove fluid. So the cell count cutoff for diagnosis of pre-PD peritonitis, I think still needs a bit of a nuisance around, what should be the cell count when we're doing a flush. That is one comment. The other comment was whether we did look for eosinophils in the cell count and whether it was an allergic kind of a PD peritonitis in the first episode. The second episode is again quite perplexing, and given that the rectovaginal fistula is there, it's the commonest cause is childbirth and trauma during childbirth, and I think that is what has probably happened in this patient, that the fistula was quiescent for many years, and then something happened where the fistula became active. It'll be worthwhile finding out whether there were problems during childbirth, including forceps delivery in any of those 5 deliveries that she's had. I can't explain the fluid, the diarrhea that occurred with the PD exchanges. There was a mention that whenever an exchange was done, there was watery diarrhea during that time, but I can't explain that. Those were a few comments and few thoughts that were coming to my mind as you went through your presentation.
Okay.
So Irene, how many attempts
Yeah.
for the second insertion of the catheter?
It's actually a single attempt. You mean in terms of
Single
during the
attempt.
procedure? Is it? Yeah, it's a single. It's not a complicated procedures actually. Yeah.
Thank you.
I mean the reason why we pursue PD in this lady also it's more of a logistic reason. The daughter was very keen to assist her, and actually this lady was it's difficult for them to get to the dialysis center. So despite the first time there was a failure with the PD that we need to remove the catheter, she was very keen for us to actually assist her in terms of reinserting the catheter. That's how we actually proceeded on for her. Yeah.
I think the point raised by Kamo is important because a PPD peritonitis, we don't have a true definition. I think that the thing that we should working on that. And anyone want to comment? Maybe Dr. Sakura, if no one comment more, so can you progress the case? And anyone else? No, maybe you can go ahead.
Okay, I continue. Okay, so peritonitis is most common complication of peritoneal dialysis. Peritonitis is associated with the significant morbidity and mortality and catheter loss and transient loss of UF, and also possible permanent membrane damage. Increased treatment cost, hospitalization, and most common reason for hemodialysis, conversion to hemodialysis. So definition of the PD peritonitis by ASPD guideline is need to be fulfilled at least 2 out of 3 criteria. The abdomen pain and so cloudy dialysis effluent. And dialysis effluence means that the white blood count is more than 100 and the polymorph is more than 50%, and positive dialysis effluent culture. So the definition of the peritonitis also can be specified for 3. According to the cause of specific peritonitis, time of peritonitis, outcome of specific peritonitis. So according to the ISPD guideline, diagnosis of the peritonitis according to the such as Staphylococcus aureus
Oh, the signal is not good. We cannot hear you. Yeah. School.
And culture negative is related peritonitis means if peritonitis that 3 months.
Oh, maybe the signal is not good, so we have to wait. Hello, Sunita.
Hello, Gal. Hello, everyone. I'm sorry, I joined a bit late. I actually was wondering at the time of the CT of the abdomen, had the catheter already been removed, or wonder where was the position of the catheter with respect to all that fistula and everything?
Hi, Dr. Sunita. As I remember, during the CT abdomen time, the catheter was still in situ. It was actually at the pelvic. I mean, it's not migrated or anything, if I do remember. Yeah.
Okay, so it was actually, yeah, all right.
But this was the second catheter, you see, after the removal reinsertions. Yeah.
Sure. So we're not sure about the first time whether that could have caused some sort of injury or created a fistula. No?
Mm,
I mean, it's just strange. I was just trying to think, how come the second time round, every time you put PD fluid, she gets diarrhea. So it suggests that your PD catheter may have some connection with the bowel.
Yep. Yep.
Probably the first attempt, maybe
During
the cause of the diarrhea, and yeah, because you can demonstrate by colonoscopy, right?
There is a fistula. I'm just wondering, yeah, you know.
Yeah, possible actually, Dr. Sunita.
Okay.
So I mean, sometimes it's insertions peritonioscopically. We know that it is very small opening. Sometimes you might not be able to see it actually, because if it's just probably a 2 mm size. If a perforation.
Yeah, so sometimes the fecal peritonitis may not be immediately appreciated. Yeah, is that what you're saying, Irene?
Yes.
Yeah, yeah. Okay, thank you.
And what happened to the second time? So because you said the surgeon is the procedure is smooth, and why is the catheter go to the vagina? Or that's the uterus or thing is bigger than usual or something, and what happened and why is the case have the accident?
I see Eddie's got his hand up. Eddie?
Yeah.
Sorry, I just raised my hand. Quick question. Excuse my ignorance, but this fistula, could it have been surgically repaired and the patient allowed to continue with PD subsequently?
I think the surgeon actually created a ileostoma. So we thought it's a bit difficult, but technically we still can.
No, it's just a thought, really.
Yeah. I know some people have done it before. It's not an absolute contraindication saying that we can't continue the PD. But looking at overall, patients was hypoalbuminemic, he was overloaded. So we decided to just put in the catheter and a hemodialyzer. Yeah, Dr. Kama.
Thank you. Look, I have a patient. It's just one patient who had a rectovesical fistula and continuing to be on PD. This patient initially had a multi-organism PD peritonitis, and that's when we picked up a fistula. We treated that, and luckily hasn't had recurrent episodes of PD peritonitis. He's just waiting for surgical treatment for the fistula while continuing on PD. And he's been on PD after the diagnosis of the rectovesical fistula for now 9 months and without subsequent episodes of recurrent peritonitis. So I think it is still quite possible to continue PD in a patient with a rectovaginal fistula and not really have multiple episodes of peritonitis. So it shouldn't be a barrier just by itself. However, given all the other considerations that you had, you've got to make a choice whether PD is the best option for that patient.
Yeah, Suguna, you want to continue your presentation?
I continue my presentation. So when there is a culture negative, we also need to be like our patient need to consider infections and non-infections. So infection is like recent exposure to antibiotic or suboptimal sample, and atypical organisms such as mycobacteria or fungal, and non-infections like eosinophilic or chemical, especially when total white is elevated but not neutrophil predominance. So catheter-related peritonitis, which will be occur within 3 months with the exit site and tunnel site infection. Enteric peritonitis also can divide over multiple microorganisms, ischemic colitis, appendicitis, or negative culture such as in pancreatitis. So definition for the time-specific peritonitis. So the PD peritonitis is defined as a peritonitis episode occurring after the PD catheter insertion prior to initiation of the PD. So these basically it starts from the date of PD initiation, defined as the day when the first PD for the PD peritonitis, the date of PD initiation is defined as the day when the first PD exchange is performed with the intention of continuing a long-term PD treatment from the first day of PD treatment. So this intermediate flushing of the PD catheter for purpose of maintaining the catheter patency is not considered as a PD initiation. So PD catheter insertion related peritonitis, what the guidelines recommended is a PD catheter insertion related peritonitis as an episode of peritonitis that occur within the 30 days of PD catheter insertion. So this based on the definition, based on the outcome of specific peritonitis. Okay, so for the refractory means the peritonitis episode that is persistent with a cloudy bags and also persistent of dialysis effluent, which is not responding to the appropriate antibiotic therapy for 5 days. Recurrent peritonitis means peritonitis that occur within the 4 weeks of a complete of the antibiotic treatment, but the period of the with a different organism. Relapsing is a peritonitis episode that occurs within the 4 weeks of the complete of antibiotic prior to the episode with the same organisms. Repeat means peritonitis episode that occur more than 4 weeks after complete of antibiotic therapy. And then peritonitis associated catheter removal means removal of PD catheter as a part of treatment of active peritonitis episode. And peritonitis associated with hemodialysis transfer means transfer from the PD to hemolysis for any period of the time, part of treatment, and for peritonitis episode. And peritonitis associated with the death means death occur within the 30 days of peritonitis onset and death during the hospitalization due to peritonitis. And peritonitis associated hospitalization is hospitalization precipitated by occurrence of peritonitis for the purpose of the peritonitis treatment delivery. So how to obtain the sample from the first cloudy bag? The sample effluent should be dealt for at least 2 hours, and there are two methods of collection of the specimen and transport. The first method is the preferable is a direct inoculation of 5 to 10 ml of effluent into the two blood culture, which is on the aerobic anaerobic blood culture. And also method 2 is we take 50 to 100 ml of effluent, which should be concentrated and supernated and inoculation on the solid culture media or standard of a blood culture media and culture to maximize the bacterial recovery rates. So they are the different a patient with the peritonitis, usually with a cloudy PD effluent and also abdomen pain, is almost represent infection peritonitis, but they are a differential diagnosis of classified according to the cellular and also non-cellular. So cellular is based on the polymorph leukocyte, which suggestive for culture positive infection peritonitis or infection peritonitis with sterile culture, and chemical peritonitis or eosinophil will suggest for the dialytic eosinophilia or chemical peritonitis, and monocyte specimen taken from the dry abdomen. And if there's a red blood cell, it's suggestive for hemoperitoneum, and malignant cell is for lymphoma and peritoneal metastasis. Non-cellular cause usually is a fibrin or TG. We can see the milky whitey appearance of effluent. And when the calcium channel blocker and also lymphatic obstruction or acute pancreatitis. Little bit of rectovaginal fistula. Rectovaginal fistula is an epithelial lymph tract between the rectum and also vagina. So mainly the etiology usually with the obstetric injury when there is a third or fourth degree of laceration during the vaginal delivery, or surgical procedure when the surgical intervention that cause a unrecognized vaginal or rectal injury. So there's an insufficient tissue between the two organs. And diverticular disease is a complex, is a common cause of fistula connecting to the intra-abdominal organ like bladder and vagina. And Crohn disease, chronic inflammatory IBD, Crohn such as Crohn disease will show intestinal fistulization. And malignancy can be cancer of intestine of adjacent organ, that known cause of a bowel population of fistulization. And radiation is and the patient is a long term of radiation chemotherapy, the long term of chronic tissue inflammation with a poor healing and also repair process. And rectovaginal fistula also divided two groups. It's a lower rectovaginal fistula, which is located between the lower third of rectum and then so lower half of the vagina, which is closer to anus, and also can be corrected with this one can corrected with the perianal approach. High rectovaginal fistula is between the middle third of rectum and also posterior vaginal fornix. This one is require intra-abdominal approach of the surgical intervention. So it also can classify by the size. The small size is less than 0.5, medium 0.5 to 2.5, and large will be more than more than 2.5 cm in diameter. So clinical preservation of rectovaginal fistula usually is a patient will present with combination passage of the rectal content to the vagina. And the physical examination, usually a physical examination of vagina can see there's a irritation, erythema, and also swelling, discharge, and stool. When possible, the fistula is opening, the speculum examination. Colposcopy can detect the cervical or vaginal cancer. Other investigation is like rectovaginal examination may reveal there's an obstructing low rectal tumor. And endoscopy or proctosigmoscopy can reveal the site of fistula with the underlying of it can show an underlying disease, Crohn, and also or diverticular or rectal cancer. So CT scan, like in our patient, where when we give the contrast, can see the outline of fistula tract, which is related to the other structure also. And also the presence of we can see the presence of rectal contrast in the vagina, which confirm which is confirmation of the diagnosis with the fistula tract itself. But we can see the contrast. Sometimes we cannot see the fistula tract in CT scan. To confirm whether it's malignancy, we need a HPE, and the management is treating for the rectal vaginal fistula is treating the underlying disease and fistula itself, and also the complication of the rectal vaginal fistula. So in our case, there is a poor outflow. So poor outflow is suggestive for the catheter malfunction. So this is a algorithm.
Sukuna, Dr. Sukuna, maybe you stop for a while. Maybe let people or fellow to approach what do they think about poor outflow for this case? Because we still have a time for like audience to raise any question or something. Okay. Anyone fellow from any country? Do you want to approach for the poor UF in this case? And also, I heard that the case also have milky discharge. I think milky effluent as well, right? If I recall right. That's a patient. Did the patient have a milky effluence or cloudy or something?
Cloudy.
Cloudy, not milky, right?
Not milky, not milky.
Not milky. Okay. Any volunteer fellow from any country? Do you want to approach for why the patient have a poor UF outflow or UF failure in this case with rectovaginal fistula? Maybe start volunteer from my center first.
Yes. My name is Vipad Kiti Viravong. I'm nephrology fellow year 1 from Chulalongkorn Hospital, Thailand. Okay, in this case, the cause of poor outflow in this case, from the film abdomen show that the catheter was malfunction, and I think this is the cause in this patient. But for in the patient with rectal vaginal fistula, we need to find the other cause of poor outflow, maybe intraluminal obstruction from the fecal content or other problem, and maybe other cause is omental wrap, and because maybe there are inflammation in the bowel, maybe it can cause a bowel edema, and maybe it can compress the PD catheter. Thank you.
Anyone else from maybe Malaysia, Indonesia, Philippines? Probably we have 3 more slides, so I think we have time. Anyone from Indonesia, Singapore, or maybe Australia, Myanmar?
Can I ask something, Golf?
Yep, of course.
May I know, was there any leaking from, maybe I because I joined late also, whether during the history, was there any pervaginal discharge, like wet, because there's a fistula, maybe the poor outflow is because the effluent is coming out from the vagina? Dr. Suguna?
Irene, Suguna is offline. Can you help to answer the question?
Yeah, it's okay. Yeah, there's none actually, Datuk Lily.
Oh, okay.
There's no history of discharge from the vaginal lah. Yeah.
Oh, thank you.
Yeah.
So have we got Suguna back online?
Yeah. Maybe Irene.
A line. Wait.
Sorry. The line is not. The line is not good. Sorry.
Okay. So Gunnar, you have 3 more slides, right?
So so when this algorithm I took from the KRT book, from a Malaysian KRT book. So when we suspect poor PD catheter flow, so first we try with the laxative therapy and also rapid flushing. If the flow is still not good, and then we suspect of the intraluminal occlusion, so we suspect of the fibrin clot. And also the same time we have to do the abdominal X-ray to look for any migrated catheter. So if there's no migrated catheter, it's possible.
But for this case, it's not applied for the case, right? Because we suspected the traumatic catheter and have a rectovaginal fistula, so we should not follow this algorithm, right? So you do you use remove the catheter, and how you
Yes,
fix the rectovaginal fistula?
We will refer to surgical for the removal of the catheter and also for the repair the rectovaginal fistula. Refer for surgical for removal of the catheter and also the repair of rectovaginal fistula.
So how many days that you remove the catheter, and how do you fix the fistula? Have you prescribed antibiotics, prophylaxis or something?
We started the prophylaxis antibiotic when admitted. So in this case, surgeon go in. They did a rectal. They did the excision and also closure of the rectovaginal fistula, and also they did a colostomy also for this patient.
Oh, okay. But you present about the fistula size. If the size small, we still do a colostomy, or whatever size is considered the same treatment. We hope that no surgeon attend our meeting, right?
The size is not stated actually. Yeah, the size is not stated in the intra-op finding.
Okay, so Gunnar, maybe we can ask, so what is the long-term surgical follow-up for the patient? Would the idea be to eventually close the stoma and correct the rectovaginal fistula? Oh, sorry, I can see Dr. Kamal's hand up. Sorry.
Yeah. Look, there's very little experience with how to manage these fistulas in patients on PD. I was just mentioning that I have a patient with a rectovesical fistula who had multi-organism PD peritonitis, but that hasn't recurred. And the plan with that patient is to keep doing PD. The surgeon has assured me that because it's a retroperitoneal fistula, and the approach of the surgeon will be retroperitoneal when he's ligating and fixing the fistula, that he would not need to remove the PD catheter. he's also advised me that there may be a little bit of spillage during this operation. And therefore, I've planned that I'd be giving this patient prophylactic antibiotics in the perioperative period and keep the catheter in. So that's, my plan for that simple patient. But here, in this patient, we've had this episodes of peritonitis that we think are bacterial in nature. And therefore, I suspect that would be the reason why the surgeon decided to do a defunctioning colostomy and then treat the rectovaginal fistula.
I think thank you. It's a good suggestion, I think. Yeah, probably because of recurrent peritonitis. So that's why, yeah, the surgeon made that decision. Saguna, can you go ahead and finish up?
So this is a summary of the peritonitis treatment, also prevention lah. So based on the ISPD guideline 2022. So with that, this will be my reference, taken from the ISPD and also KRT handbook from Malaysia in 5th edition lah. So I would like to thank you to everyone.
Okay. Thank you all for spending your time with us and for shipping in. So, but before we closing, Irene, do you want to say something before?
Yeah, thank you everyone. Thanks Suguna for presenting case. It's just that when we try to search around, rectovaginal fistula leading to peritonitis, it's not something that we can actually find much in the literature, and also try to gain more experience from our fellow colleague. Because in terms of management wise, I do think that even our surgeon himself, they are not exactly quite sure actually. Are we supposed to, like Dr. Kamal's patient, we proceed on continuing with a peritonitis, whether we want to take the risk, or we might as well just remove the catheter. So I think that those are the challenges we experience over here. Not too sure about the others. Yeah.
Very
All right.
fascinating case is what I would say, and it's always learning from each other's experiences. That's what we're all about. So thank you for presenting that patient.
Okay, thank you. Yeah.
So the recording of today's session will be put up on YouTube soon, and the link to rewatch will be I already share in the chat. Please feel free to pass it on to your colleagues and fellow before we wrap up. So could I again, could I all to switch on your camera so we can grab a group photo together? Always good to see the face behind and names across the country. Oh, that's anyone? Please open up your camera and maybe put some makeup on. And finally, I delighted to hand over the microphone to Lily Mushaha, our Deputy Chair for the ISN OSEA, for a few closing words. And see you all next time on 28th October for our next CPC by Philippines. Lily, please.
Okay, thank you, Golf. Thank you, everyone. Thank you for Dr. Suguna for educative and great presentation just now, and we've learned a lot from this study, especially from comments from others during this session. So thank you very much.
Thank you. See you all
Bye-bye.
again.
Thank you.
Okay,
Bye-bye.
bye.
Yeah, next month. Bye-bye.